Welcome to Spinal Truth Show Weekly Podcast Edition. I'm your host, Dr. Caleb Slater, and I'm here with your expert for today's podcast, my wife, Danielle Slater, an expert women's health physical therapist, an expert in your pelvic floor, an expert at treating bladder pain.
Yes, it's one of my favorite topics and diagnoses to work with.
And we are going to do something that we're trying to do a little bit more on the show. We're going to talk about the bladder pain, we're going to talk about interstitial cystitis, we're going to talk about these symptoms, these conditions, these patients. But then next week, we're going to have on a patient that had this problem and went through the treatment that we're talking about. So they're going to talk about what they went through, their journey for their diagnosis, when their symptoms started, what treatments they were offered, how effective or not effective they were, and then how and why they found us, and how their symptoms overall improved from that time. So if you're listening to us today and we're going to say some things that are going to be, let's say, controversial or at the very least not talked about before, if you're looking for that evidence, that proof, stay tuned for next week. All right, so bladder pain, which is often diagnosed as interstitial cystitis. We're going to say IC from here on out because it is just a pain in the ass to get that word out.
Yeah.
Tell me about bladder pain, IC.
Yeah, so consensus is that a cystoscopy would demonstrate a lesion in the bladder, a Hunter's lesion, and you would have a diagnosis of IC. That means there's an inflammatory process happening in your bladder, giving you this array of symptoms that include urinary frequency, pain over the area of your bladder, and just be all around uncomfortable. You know how it feels to need to urinate? Picture feeling that all the time.
Now, the people that get diagnosed with IC or bladder pain, do they always have those Hunter lesions?
That is a great question. So the consensus on the diagnosis is mixed. So now what I've been seeing is that even without a positive cystoscopy or even having a cystoscopy, if for more than 3 months someone's had pain and frequency in their bladder, they're labeled with IC.
So just based off of symptoms?
Yes.
And pain in your bladder, how can you tell it's bladder pain?
It's a great question. Usually they'll say location-wise, like suprapubic, or if you can palpate on yourself your pubic bone, which is that hard, real low abdominal landmark, right above that is where your bladder rests in your abdomen. So pain in that region, and then your urinary symptoms.
And what would the urinary symptoms be?
It'd be urinary frequency. So feeling an uncomfortable sensation and having to go to the bathroom and not really getting relief.
So they feel the need to go. When they go, are they getting a lot out? Are they not getting anything out? Is there pain with it? And then you're saying they're not getting relief. Is that relief of the need to go?
All of that.
Well, let's break it down one by one. So if they go, are they getting a lot out?
No, because their bladder's barely filling.
What's a lot mean? Like what should be a normal, I don't think amount is great because nobody's measuring it, but I think there's a time.
Yeah, I think who's bringing a measuring cup with them to the bathroom, right? For
Chris
amount.
does. If you watch this show,
okay.
Chris does.
Outside of Chris.
You know his 21.3 ounce water bottle? It's that for a reason.
Yeah, like a substantial hold of you were drinking adequate fluid, it's been 3 to 4 hours since you last went, is near close to 2 cups, right, of urine production.
What's that in the metric system?
I'm not answering that question.
I think you
We're
can't
in the
answer that
USA right now. But the color of your urine is not like a bright yellow. It's not odoriferous. It's healthy production.
I was looking. Don't they say that you should be peeing straight for like 20 seconds?
That's a great question. I think the easier way to do it is when your stream starts to count. So you go like 1 Mississippi, 2 Mississippi. You should at least hit about 12.
Okay. All right. So these people, they're likely not hitting that 12.
They're probably hitting like 2 to 3 seconds.
And when they are going, they're not feeling relief. How long until after they've gone, till they feel like they need to go again? If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you, and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
It's variable. Some of them, they never get the relief. They go, but then they still feel like they have to go, but nothing's coming out, nothing's even there. They're getting the sensation, not because the muscle of their bladder, the detrusor, is filled to its point of giving normal sensation. They're getting it because that muscle is almost spastic. It's contracting when it shouldn't.
Okay. Why is this happening? So these people have bladder pain, they have frequency, they have the urge to go. Often they have to get there quickly, right? They might even be having some accidents, but at the very least it's frequent. Why do they have this problem? What causes IC, what causes bladder pain?
What does the medical community think causes so many of these conditions that we talk about? Idiopathic, it's unknown, right? Oftentimes there can be a triggering, I had a bladder infection, but in most of the patients that I had seen, it just came on without a known. There's
no cause. Is it more with pregnancy? Is it more men?
That's a good question.
Men can get this, by the way, right?
Yes. Sometimes it's labeled as like prostatitis, where when they look and examine, there is no infection in their prostate, but they're having these urinary symptoms, and they treat it with antibiotics. Doesn't get any better, or maybe it does temporarily and just comes right back.
And I think that's a really good thing that we try to get through on this. Like, we have our own viewpoint of the medical field, and it's come after 17 years of being in it and seeing some of the failings and the misdiagnoses and stuff like that. But if you're getting treatment and you are responding relatively well, somewhere around 50%, in a relatively short period of time, somewhere around 4 to 6 weeks, okay. But if you're not seeing that, if you're getting your treatment, if they're telling you it's an infection and you took antibiotics and now they're saying the infection's gone, or maybe they couldn't find the infection but they still try to treat you with antibiotics, or whatever their treatment they're offering is, if they're doing it and you're not seeing relief, you need to consider the fact that you might have been mislabeled, misdiagnosed. So, and to the same point, a lot of these patients out there is no underlying cause. Literally, the doctor couldn't tell them what caused their symptoms, so the only thing we have to do is treat the symptoms. And it's not treatment, it's management, it's symptom management. And that's really where I get upset in our medical profession, because I'd say, I don't want to be hyperbolic about it, and I don't want to slap a number on it, but I would say somewhere in the 90s, especially when we're talking about pain and stuff like that, the treatment that's offered isn't treatment, it's management.
Yeah, it seems pretty accurate.
So before we get to what we see the problem as, and spoiler alert, it's the spine.
No.
Well, and you know what? How about this? You said the detrusor, right? Can you explain what the detrusor is?
The detrusor is just the name of the muscle of your bladder.
And what's it do?
So it has to relax in order to fill, and it has to contract to be able to eliminate your urine.
Okay, so it relaxes, allowing your bladder to fill.
And this is something that you don't necessarily control. It's an autonomic function. So your body.
But you control the contraction of it to release it, right?
No, it's passive. It's a passive movement. So
I mean, I'm pushing when
you're not supposed to be actively pushing.
I'm shaking a little bit.
So your bladder should be automatically attuned, like a reflex, to happen when it's full and you're at the toilet and can go.
But is it a smooth muscle then, like your intestines?
That's a good question. I don't know.
It's not cardiac musculature.
I'm sorry, I forget
obviously.
that piece of
Well, what type of
tidbit
expert are you?
I know.
So, all right, it's a muscle. Muscles have innervation, no matter if they're smooth or cardiac or regular.
Right.
Right? Do you know what area of the spine innervates the detrusor?
Yes, I do. So usually a lot of references will say like T11 through L2.
Okay.
Lower your thoracic, kind of where that curvature is in your low back.
Where that curvature changes in your low back. So it changes from one curvature to another, leaving that area susceptible. That's why that area is most commonly found with compression fractures, because it's an area that takes up compressive forces. Guess what area most of my patients that come in with these type of symptoms have a problem at?
The lower thoracic upper lumbar.
Oh my God.
Wow.
You are on fire.
Yes.
And doing a simple 2 to 3 movements fixes their problem. And again, so it's going to sound odd. We're saying something different than anybody else out there is going to say, but we're going to show you. We're going to show you next week. We had a patient that came in, and by the way, she's seen solely over telehealth. She was, for 2 years, diagnosed with interstitial cystitis. She was going to the bathroom nearly constantly. She's a driver for work, so a lot of sitting, bouncing. Which can aggravate specifically that area, by the way, the TL junction. She was having groin pain. She was having bladder pain laying down at night. So she was having trouble getting to sleep because the pain was really intrusive.
Yeah, if you put pressure on it, it's uncomfortable. Your bladder does not like being pressed upon, and especially if it's irritable.
And I tell you, her bladder was irritable. So, again, we're trying to think of this logically, right? And I'm always amazed on how much pushback we get when we say, hey, it might be your spine pushing on a nerve going to that area. It might not be an underlying cause that nobody knows. It might not be an infection. It might not be an itis. It might not be an inflammation that nobody, by the way, can explain why the inflammation was there in the first place. We have a linear, logical way of looking at, hey, the T11 to L2 area innervates your bladder. It might be putting pressure on that nerve signal getting diminished or on and off intermittent to your bladder would cause your bladder to be malfunction. It would cause that detrusor muscle to be probably spastic, right? Like if your muscles aren't contracting and releasing appropriately, that causes a muscle spasm.
Well, and interestingly, to go along with that, one of the treatments is Botoxing your bladder. So they want to inhibit it to be able to contract, which is a very unpleasant procedure. You are getting a needle up through your urethra, right?
They go through the urethra?
Yeah.
Really?
Yeah.
Not through, this is where I'll show my ignorance. They wouldn't do it through the suprapubis area, like the lower abdomen? I saw a procedure on a female one time, and it was a few years ago. So my expertise in the method, but it was extremely painful for her to have done, and they were poking the inside of her bladder to inject the Botox. So they weren't coming at it externally.
No, because we were looking at the camera inside, and I remember the physician telling me, look how raw and red this bladder is. This is a very irritated bladder. So it was from internally.
So, but regardless, they're injecting Botox into the bladder to paralyze it, and that is a treatment offered out there. And we're saying, hey, maybe get this area of your spine checked out and see if that's the problem.
Well, probably the most common treatment given is go to pelvic floor PT, where they're going to work on your pelvic floor.
They should do a lot of Kegels, right?
Well, actually, Kegels are kind of outlawed with IC, because if you feel a sensation to go to the bathroom, what do you think? And you're not at the bathroom, what would you do? Kind of
pee my pants?
Again? Hopefully not.
I mean, I might just be going. I might just let it go.
But no.
Where am I at? Am I in a pool?
No.
A hot tub?
You're sitting right here.
The shower?
Right here, right now.
I mean, right here, I'm not gonna, but just because there's a camera on me.
Okay. So you're gonna tighten your pelvic floor muscles, which is a Kegel, right? Or Kegel, however you wanna say it. You're gonna tighten. You keep feeling that sensation and doing that all the time. We don't wanna keep tightening more and more and more, right? So usually the treatment is, well, let's release those over-tightened muscles.
How do you release
help
them?
the bladder.
And by the way, I knew Kegels were out. I knew that's a sticking point for you.
Wow,
So I wanted to.
good job.
Well, I mean, I'm married to you, and I've heard you, and you talk about work all the time, which is ridiculous.
You know what though, to be fair, is I'm not an extremist. You have to move your pelvic floor. Like, why would we never move a muscle? So doing a Kegel is a contract and a relax response, right? You tighten it and you relax it.
Okay.
It's healthy to get blood flow and to be able to use your muscle. And if you don't contract at all, how can you fully appreciate being able to relax? So I don't stay completely away from Kegels with those types of patients, regardless, even before I started doing a spinal approach. But overall, they shouldn't just be tightening to strength.
Shouldn't be the only thing.
Yeah, they should be doing a range of motion, so to speak, with that muscle.
So what are some of the what are the things they do to like release it?
They'll do things called down training, which is like breathing, relaxation, visualization of your pelvic floor.
And I will say, and I know you're not going to like this, but there's so many treatment methodologies out there that involve breathing, and I think they're all stupid.
It's not that I'm not going to like it.
I can't tell you, I breathe all the time without training. If breathing is involved, my breathing has been pretty much self-controlled since I was born.
Hey, James Nestor has a fantastic book about breathing.
But that's not about that's breathing through your nose. That's not training.
Well, 200 pages is more than just breathing through your nose.
That's not some inane, overly specific, diaphragmatic breathing, pause, hold, down training stuff that is just, and you're like, you're not doing it right. You're slightly filling this area, not this area, and you're like, holy shit, breathing is just, you breathe all the time. I don't see how, I've never seen somebody go in, they do some breathing, and they're like, oh my God, I'm so much better.
Well, I think it has some effect on your system. Like if I'm really angry and I just take a few breaths, it's going to relax me. The idea is you're
regulation,
trying to relax
and I can get it for that, but you see it all the time. You see it applied, and you're like, this is a waste of time.
Sometimes it's become the focus of the entire treatment, and I think it's kind of ridiculous.
And maybe that's where I'm at. I'm not saying you should never do it, although I never do it for my patients, and I've tried the transverse abdominis contraction and then diaphragmatic breathing and all the stuff that Chris knows, right? All that stuff, and it just
the buzzwords.
And it didn't work. I've tried teaching Kegels or Kegels.
Really?
Yeah.
You taught patients Kegels?
Yeah, when I was able to, I've deferred to other, like especially if it was a female, I deferred to. But I've taught them. I went through a little phase of Kegels.
Okay. Was that the short foot phase?
It might have been.
Okay.
Yeah.
All right. So getting back to topic. Oh,
I want to hear about
treatments.
when do we get to the wand and stretching and stuff?
Yeah. Well, I would say that's a pretty standard treatment, right? Is that the idea is that your pelvic floor is going to be tight because it's working in overtime because of all these. And if you're in pain, what do? Usually, like, you think about something that's in pain, you guard it, you protect it. So the idea is that this pelvic floor is going to be tight. So you want to release it. That's
I thought you want a tight pelvic floor.
Who wants a tight pelvic floor? Yeah, let's not go there. But so the techniques can be an internal release where someone else is releasing, like they would release a tight upper trap on you. They're releasing your pelvic floor by giving pressure.
So the patient gives themselves pressure.
The patient can, just like it's hard to work on yourself, like to release your own muscles and massage, it's usually done by a trained therapist.
So it's a therapist doing an internal pressure release on a muscle.
Yes.
And there's a few muscles, your obturator, right?
Oh, good one. Yeah. Actually, that's the most commonly associated muscle because it's a muscle that supports the bladder.
Okay.
So
or they're teaching the patient to do it with a wand.
And then if it's successful, usually the next progression would be teaching a patient to do it on themselves. Yes, and mechanically a wand is much easier than trying to insert your own finger at this odd angle to reach those muscles.
So down training and internal release either by the clinician or the patient themselves.
And some like knowledge of your bladder.
And diaphragmatic breathing and then knowledge of your bladder.
Well, Okay, that's kind of the most important thing still. Like, I feel like most people never learn anything about their bladders. They don't know how often it's normal to go. They don't know what amount is normal to go.
But here's my problem. Yeah, and I like patient education. I think it's super important. But there's so many people out there that are peeing normally without any awareness of their bladder. I've seen Chris pee, and he knows nothing about his bladder.
What?
So why all of a sudden these people, they need to know so much more about their bladder than anybody else in order for them to pee properly?
Because their bladder is injured.
But it's not their bladder.
Oh.
It's
Yeah, I get where you're coming from, but sometimes just like.
Well, sorry to interrupt. Well, actually, I'm not. So it's down training, it's breathing, it's internal release, clinician or self, and it's bladder education. That's like
the cornerstone.
Those are the
of
cornerstone
treatment for an IC patient.
If you got 10 IC patients that came to you, or 10 bladder pain patients that came to you, how many of those 10 by doing those 4 cornerstones, how many of those 10 get complete relief? If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system, and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
Very few.
All right, I win.
I'm gonna say
Very few, give me 1? Oh, so 0.
complete relief. Yeah, usually it's not complete relief. We're talking about a chronic, lifelong condition.
No, but we're
ebbs
talking
and
about a chronically
flows.
mislabeled condition. That's what we're talking about here. It should be, you should see significant relief in a short period of time. So if you're applying these approaches and you don't even expect one of them to get complete relief out of 10, come on.
If they're 50% better by the end of treatment.
What's the end of treatment mean? How long?
4 months.
Oh my God. And you know what? And you are a literal expert in this field. You've applied these approaches. You do them better than I would say most people out there, because I've seen the amount of work that you've put in to become good at your job, right? You've trained others in this. And still, like, you just via that approach, you expecting 50% for some of them in 4 months, I think you know that's not enough.
It's not enough. You feel bad. You do feel bad in our profession. We want to help everyone, and we want to help everyone get completely better. But there are certain diagnoses I know coming in that I'm not going to be as successful as I ever wanted.
So, but now ask me that question for people with bladder pain.
Yeah, what's your success?
I would say 8 out of 10 of them, I get them more than 50% better within 4 to 5 sessions.
Yeah, I would say your odds have been better than my previous approach. And I think some of it is like I'm chasing some symptoms, right? Chasing symptoms around. And I'm doing things that are invasive, uncomfortable. People don't want to release their own pelvic floors.
Well, and how about this too? And because I'm not saying what you're doing is wrong, although I am. I'm saying it might be in an inoptimal order, because, like what you just said, you're chasing symptoms of a problem, and that problem is probably the nerve. Well, if I have a nerve problem that's going to my thigh, and my quad is weak and or spastic, right? And I'm going to approach it by just treating my thigh, which means I'm going to stretch it, I'm going to strengthen it, right? I'm going to massage it. So we're basically talking about like down training, stretching, so release, and strengthening, contraction, right? Pretty much what you're doing for these patients. How effective, how much gains am I going to see for my thigh, for my quad?
Not very much.
Marginal, right? I'll probably see some because I'm still working on the area. But what if I turn that signal on first? And now my quad gets its proper signal. It has the ability to release. It has the ability to contract fully. Now I do those same 3 approaches. I stretch it, I strengthen it, and I do some form of massage for it.
100% better.
Yeah. And that's the whole point here. The whole point of what we're talking about and what we're doing is, hey, look, people out there, they're going to get pissed off that we're saying their treatments aren't working. And you know what? They're not. They're just not working. And they might not be the wrong treatment, but they're not getting the first problem, the underlying problem, the nerve, the spine. Do that first. And now you might not even need to use the treatments. But if you do need to restore strength and range of motion and stuff like that, you are set up for success because now you don't have a spastic detrusor, right? Now you don't have is it a weak sphincter? Is that, yeah, because the sphincter, you like.
Yeah, there's sphincter involvement.
Yeah.
But
Now you have a good sphincter, right? And everybody wants that. Everybody wants a good sphincter and a good detrusor, right? And for me, it makes sense. And not only does it make sense, but I have seen it clinically. I've seen it be so much more effective than anything else. And it's a little frustrating because I look at other people out there getting treatment not by a professional, not by an expert, and they're not even getting the results that you're getting.
yeah, so how do those listening out there, patients, therapists who are interested in your methodology, how can they learn more about, be more successful?
All right, well, so patients hear T12 to L2 and their first thought is, I need imaging. If you've listened to this show, if you've read my book, you know that imaging is largely flawed. Number one, it's taken in a position of comfort. So you're not walking, sitting, twisting, bending. You're lying down for the most part. So it's already an inaccurate picture of you and your body. Number two is that findings are common in patients with no symptoms whatsoever, meaning by the time you're 40, let's say you're completely pain-free, symptom-free. If we did an MRI, you are somewhere around like 80% likely to have image findings of degenerative disc disease, herniation, spinal stenosis, facet arthritis, central stenosis, lateral stenosis.
Just like a wrinkle on the inside.
Just like a wrinkle on the inside. But remember, these people had no symptoms whatsoever. But when you have symptoms and you do get an MRI, whatever they find, they're going to say this is your problem, whether it is or not. And then finally, you can have symptoms like what you know without any findings. You know, your cystoscopy, your endoscopy, your ultrasound, your x-ray, your MRI comes back clean and you're still writhing in pain. So I'm not saying it shouldn't be used, because it should be used to rule out nefarious issues.
You don't want to miss something like bladder cancer.
You don't want to miss bladder cancer. And by the way, the patient that we're talking about for next week, she also had a cyst on her ovary. So they thought
I hear that so often.
They thought a lot of her problems were from this cyst. And I'm not saying it couldn't be.
I've even had multiple gynecologists tell me it's like the most frustrating thing. Like, it's almost never the cyst causing the pain.
It's almost never the cyst. But when they find it, they say, here's your problem. So step one is be careful of imaging. Step two, what can you do? You want to mobilize the TL to L2 area. Most of the time, this area is stuck in extension. When you walk, when you run, when you lie down, if you sleep on your back or on your stomach, specifically on your stomach, your back is stuck in extension. If you sleep on your side and your knees aren't all the way up to your chin, you're stuck in extension.
You know what, I think you brought up a great point that I don't want to forget, is that if your change in position and movement and activity changes your symptoms and impacts your symptoms, you are a fantastic candidate for this approach.
So that is a really good point. And variability. If your symptoms are on and off, sometimes they're there, sometimes they're not. Sometimes they're worse. Hey, one day you held it through the whole movie, and it was a James Cameron movie too, so it was like 3 hours long, and you were fine. Hey, great. The other day, you can barely make it through a Bluey episode without having to go to the bathroom.
That's a bad day.
That's a bad day, right?
Those are like 7 minutes long.
Those are 7 to 8 minutes long. If you're having that on and off, if you notice that like when you're in a certain position, most of the patients find relief in like the fetal position. So if you're lying down in that fetal position, you're okay. But if you're like sitting in a car and you're bouncing up and down and you're like, I have to pee every time. All right, so now you have positional, now you have variability. You are a great candidate for this. So what can you do to mobilize that area into flexion, out of extension? It's a modified Jefferson curl, and you can see, so it's bending forward.
I feel like you have to modify it per patient because not everyone has the same movement, limitations.
Well, for the most part, I teach it fairly similar, but I modify it with how much they're contracting their abs, how much weight they use, if they're going down past the floor, how much they're bending their knees. I modify that because bending their knees based on nerve involvement and stuff like that. And I say modified because the T12, the TL junction is somewhere like right here, kind of higher up than most people would think. You have to really have to be very specific about rolling your spine down in order to get that area. So for most people, if they look up a Jefferson curl, it really targets that like lower lumbar area.
You modify it to
I
be
modify
able to
it to get the upper lumbar area.
Like it's awesome, like you share that treatment. I just don't want people to think it is simple, but I think you need the guidance of you taking someone through how to do it properly.
Well, and you need to know what you need. So here's where the education really comes in, because what to expect, because you're going to be sore. Your back is going to be sore for, I tell people 5 to 7 days, but possibly 2 weeks, right? And there's also signs that mean good, keep going. There's signs that mean bad. If you're having radicular symptoms increase, peripheralize, that's typically bad. Meaning, so if your pain was in your hip and now it's running down your leg, that's typically bad. If you did have some leg numbness or some groin numbness and now it's pain, that's actually good. That's your nerve waking back up. Just like if you sit on your leg and it falls asleep, when you stand up, it's numb, then it's kind of tingling, and then it's painful. That was your recovery. Same thing happens, but over a little bit longer of a time, and it's a little bit more disconcerting when you're getting pain, because I don't want to be in pain. I'd rather be numb than in pain, but physiologically speaking, pain is better. So these little nuggets of information, how long to expect, because you'll tell people online, and my biggest following is on TikTok, and they're 2 minutes or less videos. This takes somewhere around, most of these people see significant improvements within 2 to 3 weeks. 2 to 3 weeks of doing this, and all of a sudden they're 50% or more better. But for the first 5 to 10 days, maybe not a lot of improvement, maybe a lot more soreness, maybe even worse, because we're stirring up an area that's involved.
Yeah, I think that's been helpful. So kind of, you said in terms of if people are having these symptoms and not getting success with their current treatments, reach out to you.
Reach out. Yeah, and I'm also happy to talk to other clinicians too, other physical therapists. The whole point is getting this information out there. I'm trying to come out with treatment series and book series on the treatment.
Yeah, you need an IC series.
And you keep hounding me about doing a course to train other professionals, which is probably sometime in the future. But I want this treatment out there because it's simple, because it's effective, and because I want to see our profession, the medical profession, but specifically our profession, I want to see us be more effective.
Me too.
Is there any other treatments before we finish about IC? So long story short, I think a lot of it is from the spine, and I have rationales for it too, especially because a lot of these women are postpartum, meaning they've carried a baby, your spine is stuck in extension during that time, and your abdomen is weakened, so now you've created this imbalance of a stiff, stuck, extended spine and a weak abdominal musculature that can't bring it out of that position. So again, I have my reasonings, and I feel like they're, not to overuse the word logical, but so I have my treatment. We talked about there's Botox injection into the bladder.
Medications,
but what's the medication? Was it blindness that it was causing?
That it was, and became off the market.
Do you remember the medication?
You know what, now I'm upset I can't remember.
So there's
the name
medication that's going to make you go blind, but it's off the market. But again, it does show you that.
It was like the cornerstone treatment.
It was a cornerstone treatment, and it shows you the
side effects that can happen, long-term effects.
Botox, obviously that has side effects, and it's temporary, by the way. There's down training, there's Kegels, there's diaphragmatic breathing or breathing exercises, there's internal releases. Is there anything else that these patients go through?
I mean, countless. Oh, how about having to modify your diet
Okay.
to like take out anything you love?
Well, so no coffee, no sodas, stay away from acidic, so juices,
Yeah.
sugary, what else? They got to keep a bladder journal, right?
Yep. I mean, it kind of makes you hyper-focused at certain points on your bladder where we're really trying to get the attention
Chris is over
off
here
of
laughing.
it.
He's like, I do that anyway. Right.
But I think sometimes the stress of just not being able to enjoy anything triggers their symptoms worse rather than makes them better.
And you know what? And that's probably a good place to finalize and end in the sense of how much this impacts your life. Because you think about, even if it's not pain, even if it's just going to the bathroom 6, 7, 10, 15 times, 20 times throughout the day,
all night long.
all of a sudden your friends invite you out to a place where it's an hour car ride. And you're thinking, hey, I might not be able to make that. Or a movie where you're like, I'm embarrassed that I got up for the 4th time. Or a plane ride, or a musical, or whatever. Anything that is 2 to 3 hours long and involves a little bit of traveling. And now it's inconvenient and it's embarrassing, and you'll start to recede a little bit from those activities because of it.
Life-changing.
Life-changing. And that's the cool part about treating this, is because shoulder pain is shoulder pain, and it is great to improve that, and obviously it can affect you, but we talk about really life-changing. And when you're having a problem doing the simple things that are automated, going to the bathroom, right? The breathing, stuff like that, changing those for patients, it's cool.
It's cool.
So you're gonna hear next week a patient, you're gonna hear her go through all of these treatments, you're gonna hear how long it's been, you're gonna hear what her symptoms were, and then you're gonna hear what her response was to what we're talking about.
Think the spine first.
Spine first. And again, your spine, the nerves, innervate pretty much everything in your body. Why not look at that? Why not attempt a treatment before Botox, before medications with side effects? You don't have an answer.
I don't have an answer.
You are
just because
speechless.
no one knows how to do it.
And when my wife is speechless, I'm happy. All right, so that's our show. Hopefully we answered some questions about bladder pain, interstitial cystitis. Stay tuned for next week, where you can hear from somebody personally on their journey for their symptoms. You can find us on Instagram, YouTube, Facebook, TikTok, Spotify. Reach out to us at info@thespinaltruth.com. If you have any questions, go to our website, thespinaltruth.com. See you next week.